by Air Canada, and they are tougher than the Michigan State basketball team, say, in terms of being strict to the rules. But before we start, we had a round of applause for Steve, and I want to have a round of applause for Vinay for bringing us this great place. Pretty soon, Charlie's going to be bringing his grandchildren here. So, great grandchildren, I'm sorry. So, what I hope to talk about is B cell receptor signaling inhibitors in CLL, and do we have further needs? And so not to belabor or beat on other people in the audience who are not to be mentioned, who are feeling sorry for themselves. We summarize that ibrutinib should be considered for standard therapy as initial therapy, and I've crossed out for deletion 17p because just yesterday ibrutinib was approved for upfront CLL. So for the AML doctors, another thing to be unhappy about. For second line for all relapse patients except for those on anticoagulation. Early introduction. This is where early introduction of ibrutinib may be associated with less relapse even in the high-risk population such as 17p complex. PI3 kinase inhibitors will likely have less of a role in the early treatment of CLL based upon their toxicity profile, and Jennifer Brown this fellow will give a nice presentation on this. And then finally, I believe the future of CLL will likely be centered around BCR signaling agents, although the work is not done, we're just beginning, and it's just sort of how to put this together with many of the other exciting things. So what problems do we face? And I would say, and this is already happening, the excitement of BCR signaling agents may lead us to walk away from what might be curative therapy in CLL. Yes, I said curative, and we heard Michael Keating talking about this. With these agents, few patients attain an MRD CR, and so we're going to require continuous therapy, which a lot of patients, particularly when you're young, don't like it. The cost of these long-term agents is incredible, and it really impacts patients. And then intolerance and resistance. So let's talk about these. Well, let's first talk about the excitement of these agents and walking away from curative therapy. And there were 3 papers, and I show Michael Keating's data that was published in Blood with the Italian group in the German CLL group, showing this plateau at 13 years, and almost 13 years of follow-up in IGVH mutated patients with FCR, suggesting we really might be curing a subset of CLL patients who have this group who are young and appropriate for FCR. So what strategies should we consider for this? And I would say for the small, as we move forward, for the small subset, say if we're going to stay with chemotherapy in CLL, we shouldn't abandon it for other chemotherapy. A lot of people in practice equate bendamustine rituximab with FCR, and that's totally wrong. You don't have any evidence of this plateau in any genetic group, including the IGVH mutated patients. While kinase inhibitor may work here, it's also very, very expensive. And say and we don't really have the long-term, the long-term data with these agents, so we really have to think about this. And finally, the absence of MRD in these patients. There's several studies showing this probably is the best indicator of cure. So that might be the group that we consider adding things on or doing things after if we don't get rid of disease. So given the time period to compare therapies, as we think of FCR, and we can't follow patients for 13 years to see if our new therapies are as good as this, if we're going to do research in this group, we have to sort of look and fall back to MRD negative status. And Dr. Brown has proposed a study to the U.S. intergroup to do this, to actually look at MRD negativity with a combination of novel agents versus FCR, perhaps with ibrutinib or with something else. This is under discussion, but I think this is going to be something that's exciting moving to the future, building upon what I believe is curative therapy in a small subset of CLL patients. So what about this inability to attain a CR, and with ibrutinib or other kinase inhibitors, and also the cost, which this just touched me in my clinic the other day, and I was seeing this gentleman who's a perfect candidate, received FCR, about a 2-year response, his disease is coming back, he doesn't have complex karyotype, he's 70 years or 68 years old, he's likely going to live his life on a kinase inhibitor without problems. And he wants to go to bendamustine rituximab because his insurance will pay for that, and he's going to have an $8,000 copay because he makes over 5 times, or he and his wife make over 5 times the poverty level in Ohio. So that's a real problem for a lot of patients, particularly those over the age of 65. So what strategies can we consider? I believe for the patients where we're giving ibrutinib now, giving combination therapies to both the high risk and the low risk patients to get them to MRD negative status, and then stop therapy. And I think MRD, so the first thing we have to ask is, will this endpoint, MRD negativity, translate to the same long-term surrogate benefit of survival, say, with these new agents? We don't know this. And really, given that all the studies, and we can talk about the POI, say the drug costs $120,000 a year. Why is the pharmaceutical company going to do studies to stop the drug early? But that's albeit what we're left with. The studies have been done with continuous dosing. Virtually all the studies show a survival advantage. So it's really difficult to sort of just do this off the cuff without a clinical study. And this is what we're going to need to do. And hopefully, the mindset in CLL, where we haven't transplanted a lot of patients, will move us to do this quicker than the CML field did. But this is something that's going to be important. So we think of combinations, adding CD20 antibody therapy, and we did it, MD Anderson, a lot of other groups have done it. That doesn't look like it's going to be the thing, despite CD20 antibodies being really, really important in getting us to MRD negativity. But we do have a variety of other exciting agents, venetoclax with CD20 antibodies, and CAR T cells. And I think that's a very exciting avenue to get patients off of therapy and say, after a limited period of time, to hopefully be done with their CLL. And the intergroup studies in the US are going to be focusing on this for both younger patients and older patients. So other strategies we might consider is giving these drugs early, because when the immune system is intact, there's less mutations. We may be able to get rid of the disease or get the disease down to a very small level, where CLL is like hairy cell, where the disease sets there, but it doesn't progress because you've reestablished the immune system. And also for the low-risk patients, that in our experience, so when I say low risk, the non-complex, non-17p, absent certain very rare translocations that might confer resistance, for that group of patients, none of those patients relapse on ibrutinib. They don't develop clonal evolution very often. And so maybe we treat them and then stop, and then treat again, and go to our chemotherapy-based approach. But with these, because there's so little risk of dying from their CLL as a consequence of clonal evolution. And then finally, I'm not smart enough for this, but I think we need to come up with ways to bring the drug down. And my son is an economics major, and he teaches me so much, but he says you just need a competitor, and somebody that comes in and brings the cost down. And so maybe bringing additional drugs in will bring the cost down, and this is something that we need to do. And also there are a whole bunch of political things, and there's one thing I've not heard Donald Trump say he has a solution for, is the high cost of drugs. Maybe he doesn't have a solution for anything. So I had to throw that in. So yeah, all right. So maybe I won't be able to get back though. So what about intolerance to B cell receptor signaling agents? Well, looking at our experience, we've treated 308 patients, and you see that still the big problem is, as we've looked at this data, is progression, and this is a highly group of refractory patients, but you do see reasons that other patients go off. But what's notable is half the patients or more are still on study, and these were patients that all virtually would be dead had this drug not come forward. So we won't be seeing patients like this on the future ibrutinib studies. So when we look at features associated with discontinuation, we see two things. Number of prior therapies, we're going to do away with that. We're going to be giving less chemotherapy in this disease, and age. And in fact, when we look at our patients over the age of 80, say almost 80%, we have 10, 8 had to go off for toxicity. And so I believe that this drug is harder to give to people who are older. So what are the causes of this? And they're shown here. It's more common in the older patients. Say their infections are problematic, say atrial fibrillation, wanting to go to transplant, although most of those patients ultimately died of their disease or had horrible complications of transplant. I believe we'll be doing something different than transplant in the future in this disease. And then as we look forward from even when we looked at this data, we've had a few people go off for diarrhea. say a few people that have gone off for arthrologists, so you continue to have the drop-off rate. So what can we consider? We need anticoagulation. Idelalisib is a great drug. It doesn't cause bleeding. We don't stop the drug if patients have infection. We had to do that on the early studies. And then for the other intolerant symptoms, there are a lot of things you can do to try to help. But in the end, some people have to go off. So we really need another BTK inhibitor, both for the competition to bring the cost down, and also to, for these patients that can't tolerate what's a life-saving drug. So the key questions for this is BTK the important target of ibrutinib, or is it others? And Jennifer Woyak and Dr. Kill and colleagues showed in mouse models that BTK is probably the most important things in using Carlo Croce's CLL mouse model and another mouse model. And then the other question we have to ask is, are these off targets the cause of side effects? And the only way we're going to know this is to test the more specific inhibitor in the clinic. And acalabrutinib is one such inhibitor, or ACP-196. It inhibits BTK. It does not inhibit TAC, ITK, EGFR like ibrutinib does. And in our mouse model of CLL, Dr. Woyak, this is unpublished data, showed that the survival with ibrutinib versus ACP-196 is similar. Well, as this moved into the clinic with record speed in relapsed CLL, and the data were published, and you can give this drug twice a day because it's more selective, you put better pressure on the target, and what was seen was an 85% PR, a 10% PR with lymphocytosis, and 5% stable disease, no atrial fibrillation, and the progression-free survival curve is shown here, and you get a bonus that you don't see bruising with this. As I said, we've not seen atrial fibrillation, and you don't see early progression of Richter's, even in this highly refractory patient population. Well, there's two other drugs, the Ono molecule and the Beijing molecule, that are very difficult to separate from this group. So now we have a new BTK inhibitor. Several coming forward that hopefully will be better than ibrutinib in terms of side effects. Whether the efficacy question we'll have to answer similar to what we did with the kinase inhibitors in CML. So let's talk about resistance to ibrutinib. And again, this is the last problem. And I'm talking about ibrutinib and not idelalisib because really we don't know why patients become resistant to idelalisib. There's no data to present. But when we look at our experience with resistance to ibrutinib, we see a pattern, that's very typical with early progressions, usually within the first 12 to 18 months being Richter's, and then after that almost always being CLL. Factors that predict for progression on ibrutinib include an elevated LDH, amplification of MYC, and complex karyotype. That's in the multivariate analysis. That's the strongest thing that we see. If you develop resistance to ibrutinib either with Richter's or CLL, you don't do well. The curves are shown here, particularly with Richter's. And if you're cared for at MD Anderson as well, you do the same as at Ohio State. So everywhere, these patients don't do well. Both these papers have been published. What are the characteristics of resistance? We looked at 6 patients from diagnosis to relapse and showed that the majority of patients of these first 6 late relapsers had BTK and PLC gamma 2 mutations. We then went on and looked at, all the patients with both Richter's and CLL at OSU that we had experience with, and doing next generation sequencing. In Richter's, we really found that we didn't have these mutations in the majority of patients. And in fact, I have really no idea what the pathogenesis of patients progressing on Richter's. I believe it's probably clonal evolution, or that the clone exists before and you're selecting it out, or epigenetic reprogramming. And this is under study. Well, CLL is much more clear to us now. Looking at 34 patients with CLL and doing next generation sequencing, we found that 87% of them, so the great majority, have either a BTK cis41 mutation, and most of these are the serine. We've had 2 patients that have PLC gamma 2 mutations alone, and then 4 that have the PLC gamma 2 mutation as a smaller allele with the bigger BTK mutation. And then 4 have neither mutation that we're sequencing right now for less common abnormalities. Well, the problem with this is when patients show up with these mutations and are clinically sick, they die quickly. They're hard to treat. And so we wanted to ask, could we find these early? And so we went back and looked at 17 patients who had relapsed where we collected samples serially and sequenced backwards. And what you see here is that in 15 of the 17 patients, we found that the mutation existed at a variant allele frequency of above 1%, although our assay goes down to 0.1%, at a median of 190 days before relapse. And given that these patients, we don't want to treat these patients when their disease is blowing because they're often very, very sick, we went back and looked at 112 patients where we followed them prospectively and looked for the mutation every 3 months. And what we could see is in 16 patients, we detected the variant allele frequency above 1% over the course of the year. 4 of these patients relapsed by standard criteria, and all but 1 of the remaining 12 have evidence of a small rising clone, suggesting they're going to relapse. And also have other findings, a small enlarging lymph node, which we might have shoved off before, suggesting they're going to relapse. So what are our strategies for this? And we've really moved to trying to treat molecular relapse at OSU. And adding therapies when we see these small clones come up. We're doing it with MOR208 right now. And we have a variety of agents, venetoclax, CD37 immune toxin, HDAC inhibitors, HSP9 inhibitors. This is adding this to ibrutinib and seeing if we can get rid of the clone. And then for treating clinical relapse, there are a variety of agents, and really what we need is a BTK inhibitor that's not dependent upon, that's a very good, potent, reversible inhibitor that's not dependent upon this, and hopefully there was a nice presentation by the Synesis group, and we really are excited about that molecule and others that are in the space. Venetoclax is active. I don't believe it's going to be the solution in this patient population. Richter's, I have no idea what to do with, although selinexor does have activity in these patients. An allogeneic transplant or CAR T-cell therapy should be considered for these patients. So there are a variety of strategies for preventing resistance, obviously giving these newer second-generation BTK inhibitors early, and then doing combinations. And we have a variety of exciting combinations, venetoclax, obinutuzumab, ibrutinib, lenalidomide plus rituximab, and all of these new agents, as well as CAR T-cells in the patients that are at risk for developing progression. So in concluding, I would like to say, although B-cell receptor signaling agents are transformative for CLL, we have a lot more clinical work to do in CLL to decide how we're going to best approach the therapy of our patients. Cost of therapy is going to be very, very important. And our approach is likely going to be based on age and functionally adjusted therapy. I think for younger, low-risk patients, we have to think about FCR, perhaps plus a newer therapy. For high-risk patients, we're going to be doing combination therapies. And relapse, I think, is going to become an individualized problem, that's taken care of at a small number of centers, similar to what CML is now for that disease. I would say the future for CLL is bright. And I'd like to acknowledge Amy Johnson, Jennifer Woyak, and Gerard Lazansky, and others listed here at OSU, and those outside that have collaborated with us. Thank you.
We have time for a couple of questions. John, while people are getting to the microphone, I just had a question about ACP-196. In that trial, I believe one of the eligibility exclusions was actually individuals with symptomatic AFib or uncontrolled AFib. Do you think that factored into the fact that you didn't see atrial fibrillation in your trial?
Well, so there are patients that I know went on that had AFib, which we did not put anybody with uncontrolled AFib on a study. So I don't think so, and because the eligibility with that study and the ibrutinib studies was very similar. Charlie?
This is just a comment. Your son is probably naive because the pharmaceutical industry is the only one that seems to be able to defy gravity. You just have to look at CML, where all these drugs are priced virtually the same, and it's also true in solid tumor land. It's a remarkable phenomenon, I think.
That's why we need Bernie Sanders. Is that your plug for him?
Please.
John, I'd like to say I think your son is probably a lovely individual, and we should meet him before we judge him. I'm sure he's not naive at all. But also about the presentation, I think you showed 34 patients progressing after ibrutinib with CLL, not Richter's, that had a median survival of 12 months or 14 months. So what were their characteristics? Were they IDELA refractory prior to ibrutinib, or how many of them went on IDELA or venetoclax afterwards? So
a subset of the later patients have gone on to venetoclax, and say, our experience is the idelalisib in this patient population, some of the other PI3 kinase inhibitors, if you truly have the 41 mutation, it doesn't work very long. And so they've gone on to other investigational therapies, but in our experience, those patients tend to go quickly if you don't get their disease under control.
So you think there's cross resistance there, or just general bad disease or something?
I think there's there's some sensitivity in a subset of patients, but it's generally bad disease.
John?
Yeah, just really quick. It's again about the Richter's transformation. It seems like since that's the early event, that it just, for something with the drug to cause Richter's to occur just doesn't seem biologically possible because you can't.
I would agree. In the randomized studies, it hasn't played out, and
Yeah.
I don't believe it. I believe that the predisposition exists there, and we're trying to identify a signature. And
That would pick that, yeah.
Maybe if Vinay invites me back next year, we'll have that.
Yeah, because it just seems like it potentially getting rid of the other CLL cells may give then the Richter's
Right.
competitive or ability to proliferate more that you pick it up.
Okay, and last question from Anders?
Yeah, you touch upon the financial aspects and doing trials that are realistic for the patients. So given that we have the CLL-13 trial from the German CLL group that will be started up quite widely in Northern Europe, where one arm is combining ibrutinib, venetoclax, and obinutuzumab. So what do you say about that? Is that something that is crazy to do, or should we do it?
You said obinutuzumab, venetoclax, and ibrutinib.
Yeah. all
Yeah,
the drugs.
well, we're doing that combination now because I think that is in the phase 1 at OSU, and I think that will have the chance of getting deep MRD and getting patients off therapy. But if you have to give continuous therapy with that, I would say it's crazy because it's going to cost way too much money. Thank you.
Great. Thank you very much. Excellent presentation. Our next speaker is no stranger to this audience, a true visionary in the lymphoma field, and that's Andy Zelenitz. Andy's going to speak on newly diagnosed DLBCL, new perspectives in 2016.